shouldn't be allowed. You shouldn't get the Employee of the Month award if you can get into Sally's record when she's out sick, because that means you're sharing passwords. Shouldn't be under the mouse pad. I've even seen them taped to the corner of the monitors. Okay? Password sharing should not be allowed. Okay? Don't rely on check boxes or drop down boxes. Yeah, that's good information to be able to just check boxes. That's fine. But periodically, maybe a narrative note should go in about how Mr. Kaiser really tolerated that laryngoscopy. Okay? Don't correct another's entry. Even if you know your friend and they type this instead of that, don't fix it for them. Because where's that going to show up? The M word? Metadata, the new word that you just learned today. Okay? It's going to show up in metadata that you changed somebody else's note. Tell them, you wrote this instead of that, you need to fix it. And then they can go into the record and write an addendum. And then it's very clear to the jury what happened. Okay? Follow your approved abbreviation list. Now that is coming. It's being reviewed right now at your physician level of what abbreviations you should be using. And I got an example to show you in a minute. Okay? Don't make up your own abbreviations. Not a good idea. Okay? Because when you retire and you move to Tucson, and now there's a case in question, and you say, I'm not going back to New York. That's why I moved to Tucson, to get away from the snow. I'm not coming back for that trial. It presents a problem. Okay? Here's the example. Now, this is a hospital record. It's partial electronic, it's partial written, but it's really, it's a good example of this. First of all, they had a bunch of overwrites over there. You know, they made mistakes with the time. Instead of fixing it the right way, they just tried to overwrite it. That's not a good thing to show. But I went through this chart with the facility risk manager, and we found 17 unapproved abbreviations. Things that the nurse knew, no one else did. Okay? SVN. Anybody know what SVN might be? Small volume nebulizer. Now, why didn't you all know that? Okay? All over the chart. Unapproved abbreviations. As I said, that's being done here. The list is being looked at. It's being approved. Make sure once that approved list hits your desk that you only use those approved abbreviations. And if you have some to suggest, tell people, yeah, I think we ought to add this because it's a good abbreviation. Okay? Petrified chart copies, that's what the attorneys are requesting. But a petrified chart copy is an electronic record that is locked down, that everything is there. Okay. This is the case that I talked about with the PSA. Assure that all lab tests, diagnostic studies, consultations that come back to the practice, floor it says there, okay, are reviewed by the provider. That PSA was never reviewed. No one in that practice said, where is Mr. So-and-so's PSA? It should have been here by now. The guy died from it. Okay, stage 4 cancer. Okay. Any outstanding tests should be referred to the provider, obviously. So what does Stuart Jones look for in a medical record? He looks for incomplete records, omissions, time gaps, delays. The chart should flow nice and easy. He looks for things that don't flow. Okay, he looks for contradictions and feuding and inconsistencies, failure to identify drug reactions, transcribing orders improperly, the zero is not put in the right place, or the patient says they're taking one dosage of a medication, but when you put it in the record, you put a different dosage in, and it results in a medication error. Editorial comments, feuding between employees, between whoever it might be in the record, okay? Stuff like that, Stuart Jones and all the other plaintiffs' attorneys just eat right up. If they see feuding in the chart between departments, between disciplines, they show it to the jury and they just let those two parties fight it out, okay? And cases are lost that way. Block notes are when you write one great big long note, might cover 45 minutes, 50 minutes, an hour, and you time it once, okay? Not a good idea. If you're going to write one great big long note about the entire occasion of care, make sure you put some times in it. This happened at 9 o'clock, this was happening at 09:10, this was happening at 9:20. Especially in the electronic record, because the electronic record is capturing the time that you're actually keyboarding, right? It's doing your timing for you. So if your note's going to encompass 45, 50, 60 minutes, make sure you put some times in your narrative, okay? Now I took out identifiers, so don't worry about those big white spots here. Some examples I've got to show you. Editorial comment. This patient insisted on discharge, but I have some reservations about it. What does that say to you all? What reservations? If you were the author of that note, would you want to defend that in the courtroom? Okay. Editorial comments are a problem. Okay. Use forms or computer screens that work for you. What this whole slide is saying is that if it's not working for your data entry, let somebody know. If that form just doesn't work for your clinical or your business or your billing, whatever you do here, if the form is not working, let somebody know. And I don't mean physically working like, the computer screen's locked. I mean, if the flow of information doesn't help you do your job, let somebody know, okay? Report objective facts and observed behaviors. Make sure that if somebody comes in, you're the MA that is greeting somebody and bringing them to an exam room and they're doing something strange. Make sure that somebody knows that, okay? Recording on the wrong record. That's a problem. Has it ever happened? Sure. My daughter's an RN. She was at a hospital and she wrote her great big long note on the wrong patient's chart. Okay? IS had to come in and change everything, and she never did that again. Okay? Because then she had to retype the whole note. Okay? Failure to record pertinent information, or recording meds that were given or taken, or documenting a change or discontinued medication. I come in here with my list that I know is accurate, and I give it to the MAs greeting me, and it doesn't jive with what is in my medical record. What should you do? Change things appropriately and let Dr. Kaufman know, or Dr. Perkins know. Okay? Medication management is extremely important. Failure to record what you did and what the outcome was. Example here, again, it's a hospital record. Patient's oxygen is dropping, their urine is not coming out, the patient exhausted, working hard to breathe. Nurse feels things just don't appear well. Would you want to defend that statement? This patient is that sick? I just don't think it's look good, okay? And they did all sorts of stuff for the patient. Medications and x-rays and respiratory therapy. And they didn't write down anything about the patient's response. Okay? Bad outcome. Is that good documentation with a bad outcome? No. Is it easy to defend or hard to defend documentation like that? And again, I'm not here to get you folks to write the great American novel. You don't need to do that. You can be very brief, objective, succinct, but tell the story, okay? Document things for telephone calls, to and from a patient, to and from another doctor. Maybe one of your doctors is out, at a facility and you're making contact with the doctor by phone. Document the time the call was made, who you spoke to, and what time the call was returned, okay? Then it becomes very clear in the chart, the flow, the timeline, all right? Don't simply write, doctor notified of patient's condition. That says nothing, okay? So instead, write something simple. Doctor notified, blood pressure is 210 on 150, the patient's diaphoretic, the heart rate's 1. Does that tell the story? Did it take a lot of time to write that? No. All right, but it tells the chart the story. Okay. This one here, call placed the doctor due to heart rate sustaining 130 to 150, orders received. Oops, sorry. Call placed the doctor again due to patient nausea, orders received, spelled wrong the second time.